Thank you. Good evening, everyone. Thank you for being here, and thank you to the organizers for giving me the opportunity to present today. As you know, CAR-T cells therapy against CD19 antigen, it is the most of the one promising therapy against to treat B-cell neoplasms. This therapy consists to isolate the T cells to the leukapheresis. Then subsequently, these T cells are transduced with the CAR construct and then expanded and infused into the patient. These CAR T cells can recognize, attack, and destroy cancer cells. In 2021, the Spanish Medicines Agency approved the first CAR T therapy against CD19 developed by the Academy at the Hospital Clinic of Barcelona, which we know as a ARI-1, to treat B-cell neoplasms as acute lymphoblastic leukemia. This CAR consists of a second-generation CAR and is produced in a semi-closed bioreactor called Clinimax Prodigy. However, although the cytokine syndrome release has solved by fractionating the infusion doses to the patients, there is still some limitation of this therapy. And this limitation can mention the proliferation and persistence of CAR T cells in vivo. So we can use a virus-specific T cells to prolong and enhance the CAR T cell therapy. The VSTs can be isolated and expanded from healthy seropositive donors to treat patients with viral infection. And this therapy also has some characteristics as it is highly immunostimulant to the virus and also provides tumor-specific cell lysis. Has a minimal toxicity and alloreactivity, and this VSTs product can cryopreserve and use as an off-the-shelf therapy. So these unique properties make them an ideal candidate as intermediate product as cell source for allogeneic CAR T therapy. In the last years, this therapy has increased notably, and it was demonstrated in clinical trials that its safety and efficiency, and not only for one virus, also for multiple viruses. In our case, we choose the Epstein Barr virus because it is one of the most common viruses in humans worldwide. It is highly characterized, and it is associated with some tumors such as Burkitt lymphoma and Hodgkin lymphoma. In this context, our aim is to optimize and validate the combination of these two therapies into the one, where there is a close collaboration between the hospital clinic and the blood and tissue bank. So the first phase of the project consists to generate the VSTs, and this development is carried out by the blood and tissue bank. So briefly, we start with a donor, and then we isolate the PBNCs of this donor and activate the PBNCs with overlapping peptides against Epstein Barr virus. After 20 days in expansion medium and cytokines, we obtain the VSTs. These VSTs are the intermediate product, and these VSTs are cryopreserved to generate a biobank. Then the second phase of this project consists in sending these VSTs cryopreserved to the hospital clinic to perform a transduction with the ARI in the Clinimax Prodigy. And this final product, the CAR VSTs product, the applicability can be to the patient with lymphomas associated to Epstein Barr virus infection, patient with acute lymphoblastic leukemia with Epstein Barr virus infection, or as a bridge therapy for a cohort patient not likely to receive autologous CAR-T. And with this, we expected to assure the proliferation and persistence of CAR-T cells in vivo to treat B-cell neoplasms. After testing several conditions, we replicate 5 times the optimal condition, and once in a large scale under under good manufacturing practice. And you can see in this graph the comparison of fold expansion in a small scale and a large scale. Also, we characterized the product by flow cytometry, and our product is mainly CD3 T lymphocytes, as you can see in these bar greens. From the day 12, we can obtain mostly CD3 lymphocytes, and mostly of these CD3 lymphocytes are CD8 T lymphocytes. So this is correct because the Epstein Barr virus tends to generate a CD8 T response. So the protocol for generating Epstein Barr virus is reproducible, obtaining mostly CD3 and CD8 T lymphocytes. We also evaluate the specificity of these virus-specific T cells by the production of interferon gamma, and we can see that from the day 12, we can obtain almost the 70% of the interferon gamma. And in the last day, that is the 20th day, we obtain more than 80% of interferon gamma. Also, we analyze the TCR beta chain diversity, and we can see that the diversity decreased from the day 12 because the specificity increased. And we also see or identify Epstein-Barr specific clonotypes presented by HLA molecules expressed by the donors. In bold, you can see the sequences, the CDR3 sequences that are described by the specific Epstein-Barr virus by the different alleles of the HLA molecules expressed by the donors. In conclusion of this phase, we have been able to optimize a protocol for the generation of a specific and pure T cells against Epstein-Barr virus in a small scale, and also the protocol for generating Epstein-Barr virus specific T cells is reproducible on a large scale and yields a highly specific T cell product against Epstein-Barr antigens. And last, TCR beta sequence detected specific clonotypes that recognize Epstein-Barr virus antigens presented by donor-expressed HLA molecules. So, with these results, with these good results for the first phase of the project, we performed a first test to transduce the CAR-CD19 into the VSTs to identify that our VSTs are able to express the CAR-CD19. And we used a leftover lentivirus, a liquid, and we can see that our VSTs can able to express a 40% of the CAR-CD19, as the same for the control that is T lymphocyte CD3. And also, we tested a cytotoxic assay with NAM6, and we can see that our VSTs with transduced with the CAR-CD19 are able to kill the target cells. So the product Epstein-Barr virus specific T cells are able to express the CAR-CD19 and kill target cells. However, the proliferation of this final product and the phenotype are inverse, so we have challenge. And what challenge do we have now? Improve the proliferation of CAR-VSTs product, maintain the phenotype and specificity of the VSTs, increasing the expression of CAR-CD19 in the VSTs using a fresh liquid of lentivirus. And once these challenges are solved, we will be able to validate the final product in the Clinimax Prodigy. So I want to thank to all my group in the EDVAPs, in the hospital clinic, and the blood and tissue bank, especially to my supervisors, Manel Juan and Frances Rudilla, and thank you for your attention.
Are there any questions?
I would like to know a little bit more about the phenotype of these virus-activated T cells. I don't know if they are more exhausted.
We don't tested the exhaustion markers because we think that are exhausted because there are 20 days in the culture, and for that, if you can see, we evaluate the phenotype at different times at day 12, 15, and 20, because if we can reduce the time of the culture. But in principle, we want to transduce the cells at day 20. But if we can do it to day 12 to avoid the exhaustions.
Yeah. I was just thinking that usually there is a problem with the persistence of the CAR T cells in the patient. So adding all this, I don't know if there are even worse, I don't know.
Yeah, and that is what the challenge right now, because we see that the proliferation is not good. So it's a challenge.
And then there is a product that it's called TAP cell or something like this. TAP cell? Like it's something like the model that is similar.
Oh,
I don't know. Like
I don't hear about
we
that.
can check. We can
yes,
check
thank
later.
you.
Okay.
Hi, nice presentation. My question is that you are using pool of peptides from Epstein Barr.
Yes.
Right?
Yes.
And which molecules of Epstein Barr are expressed in your...
It's a commercial pool for Miltenyi.
Yeah,
yes.
but then, and the cells that I suppose that you want to expose the tumor cells, the B cells, the tumor B cells, to these T cells that are also transfected with the CAR, no?
Yes.
And increase the capability of the CAR T cells to kill the B cells.
Yes.
So my question is, which molecules of Epstein Barr are expressed on these B cells?
When you say which molecules, you refer which HLA restriction?
No, the Epstein Barr.
Epstein Barr, but like peptides, or because the pools of peptide that we are using is a pools of immunodominant peptides that Miltenyi don't say what are,
I know
but
that.
they say the HLA restriction that they have.
But maybe I'm lost, but your lymphoma
Yes.
is induced by Epstein Barr.
Yes.
So my question is, which Epstein Barr molecules are expressed on those B cells?
You refer what type of Epstein Barrs can cause the lymphomas?
So Epstein Barr causes, it enters into latency. There are different types of latency.
Yes.
And depending on the latency program, some molecules of the virus are expressed or not.
Yes.
So I think she's asking whether your T cells will recognize those molecules.
Thank you.
Yeah.
Who will be able to contribute to lymphoma control or not.
Right now, we don't know what of these, because we use the pool of peptide that we don't know what's saying, but we think that our product is a polyclonal, so the response may be
Can I
cover.
rephrase her question? I think what she is asking is on the tumor cells,
Yeah.
do you have Epstein-Barr antigens expressed on the tumor cell that your CAR T cells are able to recognize or not?
Yeah,
So,
I don't know.
because you on Epstein-Barr infected tumor cells, those express specific Epstein-Barr proteins on the cell surface, for example. So the question is, are those cells able to recognize those molecules expressed on the cell surface of the tumor cells?
Yeah.
That's what...
Thank you for the explanation. Yeah. Yes, and I got it, but I don't know what are the specific molecules of Epstein-Barr. Yes, but I can check it. Yeah.
So I have one conceptual question that I may have missed it. So the idea is to use virus-specific T cells
Yes.
to arm them with a CAR,
Yeah.
with the idea that these virus-specific T cells will proliferate longer and persist longer than any other cell.
Yes.
And the idea is also to use these cells in an allogenic setting, or not.
Yes. In future, we want this. Yes.
So
So
wouldn't then you have an alloreactive response against your virus-specific T cell?
it was demonstrated that these BSTs has a low alloreactive because we need to partial HLA compatibility between the donor and the recipient.
Okay.
Yes.
So you have to look for a
Yes.
HLA compatibility. Okay, thank you.
Thank you.